Hey everyone, how's everyone doing? Um, I'm Ivy Stocklow. I'm a trans advocate and organizer in New Haven, Connecticut, and I'm also the Hotline Program Director for the Hotline at Trans Lifeline. So some of y'all may have seen me in some previous broadcasts, but we're super excited to be part of this panel on trans mental health. And I'm really excited to introduce all of you to three incredible people who are all mental health students or providers or professionals, and all of them are also trans peer support specialists that I have the immense pleasure of working with. So first, I would love to introduce Jackson Monarca. Hey Jack, how you doing? And
Good.
we're
How
gonna
are you?
have good. We're gonna have Amy O'Leary coming all the way from Canada,
Hey.
and Alvaro Gamio Cuervo, who is coming from Boston.
Hi, folks.
Hey y'all, so excited to see all of y'all again. So just some quick information about who you're going to be hearing from. So Alvaro uses they, él, or ella pronouns, and they're a first-year doctoral student in counseling psychology at the University of Massachusetts in Boston. And like I said, they're peer support specialists with Trans Lifeline, heading up some really important work with our bilingual services department. Jack is in the last semester of his master's program in clinical mental health counseling. He works currently as a counseling intern at APNH, which is a place to nourish your health in New Haven, right on Chapel Street. Check him out. And he also assists me with running the hotline department at Trans Lifeline. And lastly, but not leastly, in fact, mostly in terms of how many amazing projects she's been taking on in her work, Amy O'Leary is an international master's student at the University of Toronto, and she's studying social work with a focus on mental health. So she's completing her final practicum also with Trans Lifeline, and she has a background in psychotherapy and crisis management. So if there's anything any of y'all want to add about yourselves that I missed, otherwise we can just delve right in.
I think you got it.
Okay, sweet. Yeah, so I'm super excited to bring this panel to the greater audiences of New Haven and beyond, because mental health is such a frequent topic that's discussed in our community, and that is brought up somehow in the context of our community by other people all the time. You know, either because people think that trans people are inherently mentally ill, which is strange and creepy, or because people think that being trans is very hard and therefore results in mental illness, which can also be accurate, but there are a lot more nuances with that. And some of the best ways that I've found to really dispel with some of those myths and talk about the realities of what impacts our mental health as trans people and what we can do as a community and what all of our supporters can do to support us better in our search for better mental health systems and better peer support systems is to have these conversations with the people that are actually doing the work on the ground. So I'm going to ask some questions, and I definitely encourage everyone in the audience who's watching to also ask questions. Please feel free to post them in the chat. If you have a question or thought, please share it in the chat and we will address it. So my first question in general is, there's a lot of inequities in trans mental health care, just on a broad level. What do y'all think are ways that they can be addressed more broadly? Just starting broad based, what are some of the issues and what do you think are some of the solutions to them? Whoever wants to go first.
I don't mind touching on it. So for me, like as somebody going through schooling for like being a mental health professional in just about 6 months, there hasn't been one mention of trans people in my courses outside of a few academic readings. And to me, I always felt that if we're going to cover and destigmatize trans healthcare, it starts with the education of nurses and medical students and social workers and the people who are working on the ground. So for me, I always thought that reforming the medical education system to include a trans healthcare unit, because on average, medical students only spend about half an hour on the trans population in 4 years of med school. I think that would go the farthest in the long term for destigmatizing and improving trans healthcare, because right now there are a lot of inequalities due to lack of training.
Thanks, Amy. Jack or Wado, if y'all want to, I don't know if y'all want to elaborate what some of the issues that we face are, like some of the things that y'all have observed in terms of common inequalities and how y'all address them in your work.
I absolutely agree. There's just a dearth of information and from trans folks in most of the training I've had and a lot of the conversations that I've had around transness, especially for trans folks of color. I've mostly been the only person in the room bringing it up. And every so often, someone will add a piece or two, but I feel like we're always stuck in the trans 101 realm. And a lot of folks aren't projecting them forward and seeing that this is everybody's work. We all need to be asking, where are the trans folks? Where's the education on all of these issues? And asking why people aren't in the room. And I think there's a great emotional component of it where people are just scared of our lived realities, assuming, as Ivy mentioned, that we're all mentally ill. Or when we do present with serious mental health concerns, there's this individual pathology that's brought up, right? Because you're trans, and if you're a trans person of color, you're automatically going to be at a deficit. When in reality, our people have been surviving for so long and have so much resilience and coping, and we have a lot to offer in terms of teaching mental health, how it can be better.
Yeah, I definitely agree with both of those points. And just to even further, well, said of where are the trans people, in these situations, because even when you see these trans-specific clinic environments and courses about gender, and about diversity and whatever you want to call it, oftentimes it's not being taught by trans people. It's not being taught by people who are actually in these experiences, and I think very biased and very clinical, which is just not applicable to a lot of what people are actually going through.
Definitely. Had a bit of a lag there, Jack, so I couldn't hear some of the stuff that you said. But I got the general gist. Yeah, so I guess delving in more deeply, right? So I want to skip around a little bit in my questions because I think this is really relevant to something that Amy brought up. So as trans mental health professionals, right? What's some of the stuff that we're taught about working with trans community during our education? What was that experience like for y'all in your education?
So as I said in the last piece, I've only had a few instances where trans people come up, and usually it's in the context of academic journals. And when the trans population is covered, it's often in the context of tragedy. There's very few times where we've talked about a success story of a if we're going over a case study in social work of a trans person experiencing some sort of institutional barrier or discrimination, marginalization. And to an extent, I think it's just because of that stigma that we face, we associate being trans with tragedy, when in reality, there are tons of happy trans people. And I always tried to be an advocate and try to tell my professors, let's reframe this as they just happen to be trans and it's not the issue we should focus on. Because mental health practitioners do get fixated on it.
For sure. Jack?
Before I respond, is my connection okay?
It's weird, but okay, try now.
How about now?
Oh, that is way better.
Okay, cool. So I was going to say that one of the experiences I've had is that oftentimes the few times trans people are brought up at all my courses, it's done incorrectly, and I end up having to be caught in this position of, do I say something and correct people so that people know the truth, or know adequate, accurate information, or do I take care of myself and not expend that emotional energy by letting myself sit back and not always have to be the one educating? And it gets really exhausting. You always have to speak up and say that these things are incorrect, and to let professors know that they're being harmful and that they're perpetuating these harmful views and stereotypes and inaccurate information. And just having to do that over and over again, for the whole course of my undergraduate, my graduate program, in so many spaces, it's very frustrating, we're waiting for this topic to come up, and then when it does come up, it's done so inadequately. And you can just really see how the harm is being perpetuated if this is what's being taught, and this is the situation that a lot of trans students are being put through. It's not surprising to see.
For sure, yeah. Varo?
Yeah, I feel like we're talked about as if we're a myth, but also the most dangerous thing ever. I feel like I got the messaging that trans folks, especially if they have any other form of marginalization, are super emotional, especially when they're on hormones. Watch out. You always have to watch out for mood swings, that they're dependent on resources, that you have to be very diligent with assessing risk, which is true. A lot of trans people do experience a lot of high risk factors, but it was always in this liability type of language. Like, oh, those aren't the clients that you want to work with. Always the assumption that there weren't trans people in the room. And always, even when people tried to embody a strength-based perspective, it's like they weren't sure what they were reaching for. They're like, oh, I guess they teach us about gender a little bit. So it was very ambiguous language that was coded in terms of dangerousness and not really knowing how to conceptualize the cases. And I agree, always tragedy, always what if your transition goes wrong? What if everyone leaves you, which are things that happen, but not much complexity in terms of seeing them as a complex human being.
Definitely. Amy, you wanted to add something?
I was also just going to say, when it comes to mental health education, they have to follow a standardized curriculum. And what that is the checklist that the DSM provides. And when you follow those rules that were created 20 years ago, you're forgetting, two-spirit populations, non-binary people. And it's a very binary way of looking at gender as any sort of topic in therapy. And it's just generally, it leaves out a huge chunk of our population that needs care just as much as everyone else.
For sure, yeah. And I actually think this is a really good question that I'm going to interject with from the audience. So someone says, I agree with Amy. As someone in research, I think it's easy to focus on health concerns within the trans community, and we don't celebrate the positives. So for those who are in research, do y'all have recommendations on how to be more holistic in that work?
One thing I consider as a Latinx trans person is all the different ways that my community have taught me that it's all right to be trans and it might be a spiritual gift. I think there are a lot of ways and examples I have of Latinx people being really transphobic and anti-trans, and also a lot of great narratives. Like the first person to ever change my pronouns without even asking, just noticing myself as a masculine person, was my next door neighbor. She was 80 some at the time. She was a spiritual leader in our block. And she just knew, she just saw me as the person I was. And whenever I walk into a medical office, that's not something anyone's ever going to ask me. I've never had a colleague recognize that, right? In an academic space, no one's ever going to say this Latinx trans person has a way of being that we might have to record. And I think about it in my own research. I'm interested in how Latinx trans people process rejection of family of origin. I think there's so many articles. I feel like all the articles I'm reading in school are all about the awful things that we go through. And they're never about how we create chosen family, how we survive this, how we can have an amazing viewpoint of the world, and how really, we hold a lot of other people's things, and we help a lot of individuals educate themselves on topics that are unspeakable. So I think just opening that door and asking trans folks how they've survived and what they want the world to be, I think that's a good start.
For sure. Amy?
Sorry, could you repeat the question?
Yeah, just so the question from the audience was, for those who are in research, are there ways to celebrate the positives and to be more holistic in that work?
Yeah, I'd be happy to speak to this, although I should clarify I'm not doing research currently, and I've never focused on the trans population when I have researched. However, I would say that being sensitive within research also, you have to realize that statistics can be powerful. And when you're studying the trans population, you can, you often have to follow strict guidelines and what your study could do could have consequences for the community. So it's just important to remember that. Make sure you're studying something that is related to something that would benefit the community. It doesn't have to be a concern that you could study, because people are concerned enough for us already.
Hi, Jack. Welcome back. We were asking a question about research and how people can be more holistic in research around health concerns within the trans community.
I don't want to possibly be repetitive since I didn't hear what was said, and I also try to stay out of research as much as I can because I don't like it. But just generally, I would say listen to the voices of trans people and try not to make assumptions based on data that you get. Because that's one of the biggest issues that I see is either one, trans people are not even addressed during a study; they're not used at all in the data gathering system, or the data is gone and then interpretations are based on it from a cis perspective, which I think is equally as harmful because it's not actually giving the true perspective.
For sure, yeah. Definitely agree with everything that our panelists are saying. And I saw somebody mention in the comments, right, that it was really impactful to have a trans person speak to the class. And I wanted to just speak to that really quick myself. I have been on, bye Jack. Sorry, we've been having connectivity issues. I've been on a few of those panels with like medical students and with mental health students and with just like people in general, where an educator will bring in a trans speaker or a group of trans speakers like once in the year, right? And a lot of the time we're expected to like share our lived experiences and our struggles as trans people. What do we wish mental health practitioners knew? And a lot of the time it's like you're faced with like, okay, first off, you feel like you're in a zoo, but second off, you're like, how am I supposed to explain the entirety of the wrongness of your whole curriculum in like 1.5 hour thing where y'all expect me to talk about like my transition specifically and me as an individual? So it can be very daunting. So I would definitely second what everybody's saying is like, get as much data as you possibly can and get as many trans perspectives as you possibly can and actually trust them and do something with that. Because a lot of time like people listen and then just like don't do anything about it.
And I would also say, a good start is to have trans people in your program or your study to begin with. I think it's so wild how many of these studies don't, even if there's no trans person in your lab, you don't collaborate with the community. The fact that people can draft up research proposals and get all this funding, right? Have access to resources and not reallocate it in terms of payment, in terms of jobs for trans people, especially trans folks of color and poor trans folks. I think that might be a good start.
For sure. Yeah, going back to my comments that I had or questions, let's talk a little bit about standards of care. So there's a lot of changes that are happening right now with standards of care and understanding of what trans people need. Obviously, the history of the evolution of standards of care for trans people is deeply, deeply flawed and rooted in our pathologization, right? So at the same time as progress is made, there's a lot of like clashing that happens, right? With the requirements that trans people in a lot of places have, for example, to like change a gender marker, to get access to gender affirming medical treatment. Can people speak to that a little bit? Like the difference between informed consent work and like the WPATH standards, and like how does that evolution look? And what does that mean for trans people just trying to access basic care and needing to rely on a therapist in order to validate that?
So it's a really complicated issue because on one hand, especially in the United States where healthcare is often private for trans people, having a diagnosis of gender dysphoria allows you to have so much of what we need through the medical system covered by our insurance plans, whether it's Medicaid or something we get through our job. And receiving that diagnosis has consequences. It can show up in background checks. And as Ivy introduced, like these models are changing, and when you have states requiring surgery, when many trans people opt not to have surgery or have to deal with multiple year-long wait lists that could be almost up to a decade in some cases, to meet that requirement, it puts trans people in an unsafe position by not having a matching ID, and it's also invalidating. So it's important that, we keep these progressive standards, but we also have to realize that they do present challenges because the old standards are still present in many legal areas.
For sure. Jack or Wado, whoever.
Absolutely. And I think it's such a peculiar position. I don't know if you all feel the same way as a trans clinician to be that gatekeeping aspect for someone's surgery or hormones. And I think there's such an aspect that people forget around psychoeducation, why these laws exist and the different mental health effects that can take place when people need to wait so long to receive their transition care. And oftentimes I find myself having to talk to colleagues of helping clients come to terms with that, right? Understanding that there are all of these systems of oppression and laws that exist that work against us, and also helping to cultivate hope to keep going and keep accessing these things. And so oftentimes I feel like a lot of trans clients are aware they're not living in the world that's built for them, and it's not quite going to serve them in the right way. But clinicians are very, let's get to the point of it. These are all the laws. This is everything you need. But that human aspect of how are you feeling, the fact that you need to wait so long. So I definitely agree with you.
Jack, you want to try again?
I will try and hope for the best. Apologies for the connection issues.
You sound good now. Fingers crossed.
Yeah, fingers crossed. Don't jinx it. But I definitely agree, especially with what Vado brought up about being a trans person in the field and really realizing that now you're kind of a part of that system that's upholding these standards that are so harmful to the community, even if they are considered more progressive, based on other standards. So it's a really hard, spot to find yourself in, to figure out how can I still give my trans clients what they need, while protecting my licensure and protecting the things that I need to do, to stay in this role where I can be of that kind of help. So it's a weird spot to be in. And it's also important to really recognize, what looks like a progressive move in the field can be so small for a trans person, because, since being in clinical mental health counseling, I see people celebrate after having a pronoun line added to an intake form, after years of pushing for that to be included, and that's considered a victory, and that's good. I don't want to, push down on that. But for a trans person, that's like not even bare minimum, that's so far below, because even when there is a pronoun line, you can almost guarantee it won't be read or respected. So even looking at what standards are in the field, of what progress looks like, can be very disappointing. And I think it's really important for us to realize that what looks progressive to the outside is not actually progressive in our community. It's years and years behind what we actually need. And what a lot of people are, dealing with right now is not being acknowledged or
For sure. Yeah, so moving on. Let's see. We got a bunch of time and we got a bunch of questions. So actually, I had a question for Amy, because you mentioned the specifics of mental health care in the United States, and you've lived and studied in the United States, and you're now living and studying in Canada. I was wondering if, because like you hear a lot from our community, right? People are like, oh my God, everything in the US sucks. I want to flee to Canada. And I was wondering if you could speak to that a little bit. Like, should people be fleeing to Canada? Is care better in Canada? Like, what are the pros and cons? What's it like? What should we expect?
Yeah, so I was one of the people who decided to flee to Canada and took it a bit too literally and did it for real. I don't regret it. However, I will say that Canada is not the paradise for trans people that it's often made out to be. Culturally, I grew up in upstate New York, and I'd say that Ontario, I specifically live like in Ontario. Ontario has a very similar culture, and I really you know, would say that it's comparable. In terms of healthcare, it's weird because on one hand, I'm suddenly not paying for things. And it's weird to walk out of my endocrinologist's office and not hand the receptionist my credit card and pray that, it's going to go through. Instead, I'm just able to walk out after swiping my health card. At the same time, there's extremely long waiting lists for trans care in Canada. And part of my work at Trans Lifeline is that I've been improving our resource database for the American operators to help find resources for trans callers in Canada. And something we've noticed is that resources are few and far between, especially in Northern Canada. Wait lists range for like a one-time gender therapy assessment between 3 and 4 years sometimes in some provinces, not Ontario, but Nova Scotia and Eastern Canada especially, there aren't many options. So people are stuck with these waiting lists, and many people do opt to go into private care. So it's really something that you have to weigh. If you can get into the public system, it's amazing. Surgical care is also covered through the plan, something rarely seen in the United States. However, there's just that waiting time that for many trans people, it's not going to be realistic.
Just as a follow-up to that, so in the US, right, there's a lot of kind of variation in terms of informed consent options. What does that look like with the Canadian healthcare system?
So believe it or not, in many ways, Canada is actually behind many of, at least the more progressive states like California, New York, many New England states, in terms of updating things like gender markers and especially receiving a diagnosis that would lead to hormone therapy or surgical treatment. So, many people, again, have to wait a very long time. But not only that, the informed consent process is only available in clinics that specifically offer it. It's not part of the public health system. So you have to go to a private clinic, and they rarely take public health care cards. So you'd be paying out of pocket.
Yeah, that super sucks. And I know I've worked with a number of people who have experienced challenges with the Canadian healthcare system as like international students specifically. And I know you're an international student. So like, I don't know if that's something that you can speak to, but like I've connected with a bunch of people who like are studying in Canada or who are there temporarily and like run into that issue. Like, is that something that's still a problem?
Yeah, finding medication when I first came here as an international student was extremely challenging. I'm a binary trans woman and I transitioned 6 years ago. So I've been on hormones a long time, and many doctors still treated it as if it was a first-time appointment. And, I understand that in many ways, but it was frustrating. And as an international student, I do have to pay into the public healthcare system, and it's far cheaper than the USA, but I'm still paying every year a couple of $1,000s in order to make sure I can use emergency rooms. But yeah, it's an ongoing debate, and it is improving in Canada. However, the rate that it's improving is far slower than it is in the USA.
Cool, thank you. So yeah, after that Canada foray, thank you, Amy, for being our voice of informedness. I guess so. Let's see. I want to talk a little bit. I want to switch gears a little bit, right? So we've been alluding a lot, like all of us, to the specific risks of like a trans person going into the like mainstream mental health system, like interacting with clinical entities of any kind. I was wondering if y'all could speak kind of frankly to what are some of those risks of a person like seeing a therapist, seeing a psychiatrist, interacting with that system. And I think after that, I'm going to want to talk a little bit about like what are alternatives that are being built, right? Like not to toot our own horn, but like Trans Lifeline is an example of that. But I think, like, there's a lot of people who are exploring ways to reduce harm from systems that are built that are often built to not support us. So I was wondering if y'all could speak a little bit to some of those risks that you've observed and how you kind of reduce harm around that as practitioners.
Well, a lot of the work at Trans Lifeline that we do, and also I find myself doing clinically and in research, is studying how folks are hospitalized and how people treat trans folks as dangerous when they experience really chronic suicidal ideation or thoughts and behaviors. And there's a very real risk of going to an inpatient hospital and experiencing medical trauma. I mean, we hear it on the line all the time, and I feel like I've had a couple of clients just turned away when they were actively suicidal, and the providers, unfortunately, they were aware of the situation and just said that this wasn't the space for them. There's also the risk of not being taken seriously, right? I think there's an extreme that our field does, where it either dismisses trans folks and doesn't believe the lived experiences, or it really emphasizes the identity and emphasizes the risk, and then as a caution, institutionalizes folks. And as Amy mentioned, a lot of these experiences can show up on background checks. And when you look at the mental health field as a tool of surveillance, right, the fact that inpatient units, hospitalizations, they can act as a carceral system. They can limit your movement, they can limit your rights. It's just another form of oppression at times, especially when trans folks of color are overrepresented in these systems, and when individual mental health clinicians aren't trained to build space between these formal supports that can be very violent, right? Sometimes inpatient might be the best option for a client, and sometimes they'll consent to it. But other times, clients might want to make space between these systems and they're not interested in formal support. So, what are the ways that we can help them? I think it takes a lot of creativity that at times our field isn't ready to embody and isn't ready to think about, right? To think about community spaces of care. A lot of the community connections that would hopefully happen in a trans space have been medicalized. The fact, and I see it all the time when people walk into my office and they light up. They're like, oh my God, a trans Latinx person, you're the first person I've ever interacted with. And a lot of my work is to help them get acquainted, right? We need to diversify our interventions. And I feel like I'm getting a little bit ahead of myself, but I think those are major risks, risk of accessing care, just the deep medical violence and trauma that folks face explicitly, but also all the little implicit and indirect jabs that clinicians can take towards trans folks.
Yeah, following up on that, I was going to say that when it comes to things like inpatient treatment, I worked as a trans person in psychiatric treatment for years when I lived in the United States. And my work was as a crisis manager, which essentially is somebody who de-escalates somebody who's very heightened or having a very difficult episode. And there were so many different times where a trans person would walk through the door. And I don't think people realize how traumatizing inpatient is for somebody who is trans. There's gendered rooms that are shared very often. There's gendered bathrooms that sometimes aren't even private. And you also lose access to your clothes. You lose access to your ability to do self-care a lot of the time. And those things are so disenfranchising. They're dehumanizing. And not only that, a lot of trans people who are experiencing some sort of psychiatric crisis are in need of support socially, not psychiatrically. So something in their social system, maybe they are facing housing discrimination or they lost their job due to being trans. It's not always a mental health thing, yet it can present as a mental health issue. And that's what social work tries to focus on. And I really wish health practitioners looked at it more importantly, but I do think as a trans health practitioner, I was able to see that more often than my cisgender counterparts.
For sure.
Yeah, and
Jack?
because of the risks, that Baudo and Amy are talking about within institutionalization and hospitals and things like that, we really see an issue with trans people not being able to be honest and open, even just in an individual counseling session, or an environment like that, because I know that that's a risk that could very well, be down the line. And oftentimes I have to warn trans people, if you're going into a clinical setting, you might not be able to be honest, especially because there's a big stigma around suicidality in general, and ideation, and people treat it as though it's a crisis or it's an emergency, and it's not common. And the reality, unfortunately, for a lot of trans people is that suicidality and ideation are very common and are a normal reaction, to the things that people have to go through day in and day out as a trans person. And when people aren't given space to bring that into a counseling session and say that that's a normal experience and it doesn't need to be treated as an emergency, they can't really get proper care because they can't be sincere, with what's going on. And it's difficult because there are ethical standards that we have to follow as professionals, where people say they're going to harm themselves, we legally have to do something, if we want to keep a licensure. And it's a very delicate balance. Trans that's not if they're not consenting to that and actively asking. So it's a very difficult balance, and it's a hard thing to have to juggle. And oftentimes it just comes down to people not being able to be honest, in this space where they should.
For sure, yeah. That's super real. And I think we can all speak to like the importance of it having a truly anonymous and truly confidential informed consent based peer support space. And right now, there's a lot of discussion, there's a lot of discourse happening um, with providers, sometimes with peer support organizations, who will sometimes come to Trans Lifeline and be like, "Hey, y'all have a policy. You don't call the cops on people. You don't call emergency services on people unless they ask you to. How do y'all do that? What do how does that work? Like what is the deal with that? Like don't you kill people by doing that?" Like that's always like a question that we get. And then lately, because the discourse has been changing and more people are suddenly getting woke, in some way, shape, or form, or so they self-describe, people will come to an organization like Trans Lifeline and be like, "Hey, we'd like to involve police less. How do I do that?" And I think Jack touched a little bit right on that in terms of like being transparent with what the requirements are of your position. Being very transparent with a person about like, here's what you can say to me, here's what you can't say to me if there aren't consequences. But I was wondering if y'all could speak a little bit more too about like what are ways that you've effectively used harm reduction yourself in your work with clients, or in your work on the line, in terms of how you've seen that manifest, in terms of like really centering a person's agency and a person's consent while supporting them.
Um, it's difficult, as a trans person myself, oftentimes when I'm working on Trans Lifeline, we're talking about things that I've been through, or I'm sure these, all of you have been through when we talk to people on the line. And, I think the biggest thing to think about is to look back to when we were facing those issues, if we have, and to think, what would we want? And something that's so important and often forgotten in therapy is asking what the client is there for. And on Trans Lifeline, oftentimes, having somebody ask you, how could we help you? What is something that we could do to, make things a little bit easier? And if that's just listen, it's amazing. But also being able to offer somebody resources feels incredibly rewarding. And if we can avoid police contact by doing that, it's all the better. So, yeah.
Absolutely. And I think something that I include as a trainer at Trans Lifeline and in conversations with colleagues is really thinking about the long game, right? Having that forward thinking. It's a little ironic because we tell our clients to be forward thinking to facilitate hope and resilience, but ourselves as clinicians within a system, sometimes we lack that insight to be forward thinking and considering maybe this drastic intervention might help in the short term, but in the long term, is this going to have is this going to give my client a lot of trauma? Is this going to give them a fear to access resources? And I don't know. I'm in the business of working ourselves out of this profession and hopefully helping people be healed as whole human beings. And I think there are so many different ways to go at it, but the ones that are coming up the most for me is eliciting consent for interventions, right? Oftentimes we talk about ourselves as the experts in the room, but truly our clients know their lives better and know what's best for them. And so it's really a collaboration. And before you ever deliver something, always eliciting consent. Do you want to hear the information I have? What are your options? What have you tried already, right? Not assuming that people are walking in not having tried anything. Maybe they have been hospitalized and have had an awful experience and don't feel comfortable telling you. Naming your location and naming that these systems can be really violent, that can do so much service, especially at the intake, when you frame your clinical work as anti-oppressive and frame that a lot of mental health concerns, as Amy mentioned before, they come up in terms of psychosocial factors, but really the root of it can be different violent experiences that you've had. I mean, it's a normal reaction to feel suicidal when everyone's disrespecting you. And I think that makes the work so much more beautiful and so much more fruitful, because then you can get into conversations that are really profound and genuine, and they can turn really existential, right? I think a lot of questions of why should I live this life if everyone's mistreating me? What is the point of all this pain? And I think that work is harder, and a lot of people aren't ready to do that work because I don't have an answer for it. And I feel like we live this life for so long and I still don't have all the answers. But really, I think that's what's going to get us long-term healing and liberation.
For sure. Jack, did you have anything? And then I know Amy had a follow-up.
I do. I'll keep it short and sweet, though. I mean, Vado and Amy said it beautifully, and essentially I do the same thing. I mean, I approach it as a collaboration with my client or whoever it may be. What are you looking to get from this? What is your goal for the future? Where would you like to see yourself? And what have you already tried that didn't work for you? And tell me about those experiences, because they're going to be the expert on what they need more than I ever will be, no matter how much of their situation I know. So the more information I can get from them, the better I can tailor my approach, rather than just taking that jump and doing something without consent that could have this huge harm risk or trauma, that's come with it. So exactly mirroring what everyone else already said. I'll just leave it there for.
Thanks, Jack. Amy?
Yeah, and I just want to highlight, just in case there are aspiring mental health professionals watching, but you should always treat a disenfranchised population as a population that needs to be given agency in your work. You, as a practitioner, need to be able to step back and realize these people are often told what they should be doing. And, as trans people, that is often the form of pathologization and all sorts of things, but it doesn't just happen to trans people. It's a BIPOC issue. It's a huge issue among so many marginalized populations, and just realizing that the client always knows best is just the best mindset to have.
And I also want to say to any trans folks out there, especially trans folks of color who are considering this field, I know it can be really abrasive, and I'm sure everyone on this panel has had their share of awful experiences, but there can be very beautiful experiences as well. And so you can make this space for yourself. And I think the field isn't quite where it needs to be, but there are different pockets that you can find. I think Trans Lifeline is one of those pockets. I feel like my academic program is becoming one of those pockets where you can really grow into who you want to be as a clinician. Yeah, so we're here.
Amazing. So actually, Amy and Avado both touched on a thing. I guess I wanted to, if we're going to dig in a little bit deeper in our last kind of time here. So within our community, right, who do y'all see being most disenfranchised, and in what ways, right, by the mental health care system? And what are ways that both people within our community and also practitioners, how can we advocate for the most marginalized trans people? Because y'all mentioned trans, BIPOC, traditionally are the most at risk, right? When we train people on our hotline, we always talk about like, are you prepared to take on the risk of, you know, bringing the police to a person of color's door, right? Are you willing to take on the risk of somebody being sexually assaulted in a medical facility? Um, and a lot of time people answer no, like we want to avoid that. So like that's how we talk about informed consent. But what are some other ways that like we can really hone in on talking about people that are most at risk in our community for violence by these systems?
Um, I think one thing that's easy to forget are a lot of invisible populations, such as people who have chronic illness, invisible, disabilities or require accommodations. And that does actually disproportionately impact the trans population, because this entire conversation has been about how our medical care isn't taken seriously. And when those populations are having their diagnosis ignored or possibly can't get a diagnosis because no practitioners will take them seriously, or they're experiencing trans broken arm syndrome where everything is blamed on their transition, it's incredibly disenfranchising. And I have trans peers with fibromyalgia and some chronic illnesses that, you know, are also hormonal and can be very complicated when you're trans. And as a practitioner, being able to check in and being mindful of those barriers is important. And I'm sure, there are so many other populations that are forgotten, but I really wanted to make sure that got mentioned.
I'm thinking about a lot of the work we're doing now and building the Spanish extension for the hotline, and how few resources there are in any language that's not English in the US, and how difficult it can be to help train um, clinicians or peers in our community about just the whiteness of how we identify gender, and how everybody has all their different types of being. I mean, there are as many ways to be trans as there are trans people, and really making space for that and allowing someone to take agency, especially since naming your identity is one of the biggest protective factors against all of these serious mental health concerns. I mean, increasing those resources and elevating folks of these populations, right? Trans folks of color, Latinx trans folks, into the profession and as peer supporters is definitely an amazing way. And an example I see in clinical work all the time is how issues about oppression, especially how race and transness intersect, becomes this pathology. Oh, well, this person is just confrontational because they're always bringing up their race and they're always fighting with me about things I do wrong. So it must be borderline. I mean, it must be this personality diagnosis, which I see very often, and it takes some type of grounding and humility as a clinician to maybe take a step back, take a deep breath, acknowledge that you're in a position of power, right? And that maybe you consider some personality factors, but ultimately bringing up these issues and demanding your client rights, right? What you deserve in a clinical session, any type of medical facility, of being acknowledged by all of your intersections and all of the oppression you face that then contributes to your mental health care. I mean, that is not a big ask, or at least it shouldn't be. And to really suspend judgment and try not to pathologize, I mean, bringing up everyday experiences and bringing up different factors. I feel like sometimes we ask trans folks of color to tell us what they're experiencing, and then we don't really like what we get. So then we kind of want to challenge it and push it back, and then think within a pathology mindset. So I think holding all of these things together is a step forward.
Yeah, absolutely. I also see a lot of conflict come up when it comes to comorbid mental disorders, along with being trans, because of course people still pathologize being trans in general. And if somebody has mental illness, especially if it's a mood disorder, if it is, associated with all of those type of things, people often gatekeep and say, well, we can't let you have trans healthcare because you have this other thing going on. We can't trust your judgment, or we can't allow you to address that until you address this that's going on. And one takes away the autonomy of assuming that person wants, that to be pathologized or to be addressed in whatever way, it's being medicalized. And two, really ignores the fact that their dysphoria, other things that may related to being trans are being exacerbated by not being allowed to have this healthcare that they need, whether that be transition related, whether that be, gender therapy, whatever it is they're looking for, being kept from that and told, no, you can't have that until you address these other mental health concerns that we're putting on you. It's just another form of gatekeeping, and is ultimately most likely going to exacerbate the pre-existing other comorbid disorders that they may have or other mental health issues that they're experiencing, because they're not allowed to be their authentic self. They're not allowed to access these really like life-saving interventions that they should have the autonomy to be able to ask for and receive without getting consent from a doctor who really shouldn't have a say in whether they get to have that or not.
For sure, yeah. And I'll add my own little bit to this too, in terms of like one of the most easily harmed populations within all of this, and obviously there's all the other intersections that people named, is youth. So people under 18, a lot of time, right, when we work with folks who are reaching out for peer support, who are looking for resources around either social transition or legal or medical transition, a lot of the time, so much of that just like comes to a grinding halt because young people under 18 do not have legal bodily autonomy over what happens in terms of their transition. It is the decision of the person who is their legal guardian. Um, and so in that particular situation, any practitioners who are watching this should really, really keep in mind, you hold a lot of power when you're working with a trans young person. You hold an enormous amount of power. You could potentially influence their family in a positive way. Sometimes you'll be working with a family who thinks, they refuse to believe their child. They refuse to listen to what their child needs, which is a problem in and of itself, and it's usually a sign of like not very good parenting. But in a trans context, they might be listening very badly, and then suddenly when you come in as a professional and say, yes, I am agreeing with your child that they do in fact need to transition, you know the parents will maybe sometimes listen more often. So really, really like contextualizing the power that you hold as a practitioner, and the ability that you have to advocate for a young person, the ability that you have to be a safe space as an alternative to the other adults in their life, is super, super, super important, and something that we run into all the time in peer support. Yeah, so what else? We have just a few minutes. I guess my question, I can put together two questions that I had. Oh, Lado, you had something to add. Go ahead.
Well, I just wanted to thank you for bringing that up, because oftentimes I feel like trans youth are in one of the most vulnerable positions, where adultism kind of takes center field, and a lot of the violence they face isn't taken as violence, right? Chronic misgendering after stating your identity, that is a really high risk factor for suicide. Taking away transition materials such as binders, clothes, makeup. It's a really big affront for trans kids, and past blocking transition, knowingly leaving trans children in spaces where they might be physically assaulted. I feel like it's something we see often. All of these different ways of being that cisgender parents take up that isn't made legible as violence for clinicians.
Josh?
Yeah, and also on that same note, I think it's important, as clinicians who may work with the parents and, loved ones and friends of trans people to look at what stigma you might be perpetuating, depending on how you respond. Even with the common tropes of, people grieving over, a loss of a child because they feel like they're losing their daughter or their son, whatever it may be. And, looking at what do you validate in that, but what do you challenge and say, but are you really grieving? Is that how your child views it? Have you talked to them about how that might be hurtful or harmful to them? To push that narrative of saying that you're grieving someone who's gone and they're right in front of you and trying to tell you who they really are. So I think it's just an important thing to keep in mind, is even when working with non-trans people who are in the lives of trans people, and looking at, what you are challenging within that, so that they're not further harming their child in an unmeaning way.
For sure. So let's see. I guess I'll double up a question. So if you could say something to mental health providers who are either working with trans people or are looking to work with trans people or are worried about working with trans people, um, what would you say? And the second question that was going to kind of mold into that was like, what are ways in general that we can improve our standards of care? What should our goals be? What do you want people to know? What do you want people to prioritize?
I mean, I guess like one thing to say is like the trans client is definitely more scared of you as the therapist than the other way around. It's you know, an incredible position of power, especially with a transgender person where you might be writing their letters for hormone therapy, or you might be helping them with family counseling and encouraging their identity to be validated by their family. There's a lot of, you know, privilege in that position, and being able to realize that, and also realize like this person is coming to you trusting you and saying like, I'm confused about this, I know you aren't transgender, but I need help still. That's a really vulnerable position for somebody to be in. And just as a therapist, being able to ask what is the best way that I could support you, because therapy is not always needed, um, and you know, providing them that space to lead the conversation, at least initially, in order to meet their goals and not your own. And with regards to the standards of care, I would advocate for continuing for progressive change and reform towards the WAPATH requirements, as well as the WHO requirements. It's progress that being trans is no longer considered a mental illness in the DSM, but the pathologization of trans people is continuing. In many places it's getting worse, like in the UK, and it's important to remember that this is as easy to go back as it is for us to pretend that everything is still going forward, and to realize that, you know, you also can protect people with your voice. So that's it.
My main message to providers who are cis would be to be with us spiritually and personally as much as you are with us intellectually. I think it requires a different type of presence and strength and energy to be with us in this work and not put it down. This needs to be everybody's work, period. And even if you're not seeing a trans person that you know of in specific, you're seeing cisgender people who will interact with trans people. And so what is the way we can incorporate all of this together so it is always our work, and that anything we do in this field will further help liberate trans people and help trans people be their full selves. And I feel like we've mentioned so many things. I could make a whole list, but ultimately what I want to highlight is to elicit consent, right? And not think that you know what's best for trans people, and to diversify your interventions. Certainly there are individual interventions and different psychosocial factors you can elevate, but there are also a lot of community interventions. And that's really, I think, what makes health long-term and more consistent. Helping a client interact with community and helping them make sustainable changes in their life.
Yeah, just seconding, I mean, all of that. I don't really have a whole lot to add aside from just do the research, you know what you're talking about as best you can, and acknowledge that you're not going to know everything, especially if you're not trans. And even if you are, like I said earlier, there are as many trans experiences as there are trans people. So even if you are a trans person, you are not going to know, everything that someone is going through. And even referring people out to other trans spaces is not always a safe thing to do, because some of them are, for example, heavily white. They can be very clinical. They can be unsafe spaces for a lot of people. And just being able to say, oh, well, here, also use this trans support space so you're not alone. That's not always enough, and don't rely on your trans client to teach you these things, or to have to constantly retell their trauma and retell their negative experiences for you to learn and understand better. Take the time, do the research, do it specifically with cases so you're hearing the voices of trans people when you're doing this research, and then use that to incorporate it into your care to make sure you're doing the best care you can.
Definitely. Thank y'all so much. I agree with what everybody said. What I always like to harp on about, the people have probably heard me say before, is it's really, really important to internalize that like a lot of what we're taught as mental health people is truly fundamentally, foundationally built on a basis of systemic transphobia. That is the reality of the history of our field. That is the reality of the evolution of our standards of care. And you know, all of that is contextualized within systemic transphobia, within colonialism, within systemic racism. And we have to do the work to undo that. We have to do the work to reduce that harm. And like Lado said before, the best way to do that is by acknowledging it and acknowledging that whether or not you're seeing a trans client, whether or not you know that you're seeing a trans client, because you might have clients who just don't want to come out to you. There's always, always, always work to be done, and there's tremendous amounts of power that you hold. And there's always change that you can make if you continue to do the work, both inside your office and outside of it. Yeah. So if anybody has any questions or wants to learn more about Trans Lifeline, you can find us at translifeline.org. I don't know why I can never say org correctly. But yeah, thank you so much, y'all. Lado, Amy, Jack, thank you. Y'all are incredible and you do amazing work. Definitely get in touch with us if you want to collaborate sometime with Trans Lifeline. I have one last little pitch to give y'all before we bounce. On behalf of the New Haven Pride Center, so thank you so much to the New Haven Pride Center for hosting this. Thank you, Patrick Dunn. Thank you, JC, for setting up this. Thank you, Mr. Elliot Olson, for like creating this whole week of events. It's been amazing. And I want to personally, from my own perspective as a trans person in the New Haven community, and also from somebody who's worked very closely with the Pride Center in my capacity as program director with Trans Lifeline, I really, really, really want to encourage people to donate right now before December 31st. Every dollar that you donate to the New Haven Pride Center at newhavenpridecenter.org/match, it's right there on your screen right now, is going to be matched. So the Pride Center got a $25,000 capacity building grant, and they're trying to make it into $50,000. And why that's exciting for me is a huge part of that money is going to go towards trans programming. And there is such a need for competent, amazing trans-led trans programming in our city and in our state. And this is an amazing opportunity to expand not only that, but also women's programming, BIPOC programming, Latina and Latinx programming, all sorts of programming specifically for the people that are least represented in our LGBTQ plus community in Connecticut. So please, 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 I as a trans person am asking you to support the match fund. Definitely go to newhavenpridecenter.org/match, make a donation, and check out all the amazing work that the center is doing. And if you're trans, feel free to get in touch with Elliot Olson at trans@newhavenpridecenter.org to suggest programming or to say this is something that I want to get involved in. Thanks y'all so much. Love y'all. You're amazing. And happy TDOR, and see maybe some of y'all at the vigil tonight at 5:30 on the green.